All right, we will continue here. So this is what I wanted to show you what a sinus rhythm looks like with a 12-lead ECG. This class again is learning how to do one view monitoring. We are not learning how to interpret a 12-lead ECG in this portion of this class. But you'll notice here we have lead 1, 2, and 3, AVR, AVL, AVF, V1, which is equivalent to MCL1. Our modified chest lead 1 is equivalent to V1 on a 12 lead, V2, V3, 4, 5, and 6. And then usually either V1 or lead 2 will come as a continuous strip down along the bottom. Now you can see that our waveforms look different in all of these strips, and each section of this will tell us about a different part of the heart. So the thing we have to remember, if we're monitoring in lead 2 and our person's complaining of chest pain, just because we don't see any changes in lead 2, it doesn't mean there's not changes in other parts of the heart. So when you have a patient who's having an abnormal rhythm or complaining of chest pain, you always want to make sure you get a 12-lead ECG. And usually on a telemetry floor or in an intensive care unit, that's fairly standard. You'll usually have standing orders to get a 12-lead ECG with chest pain. So we looked at a basic sinus rhythm, but I also want to talk about sinus rhythm with a bundle branch block, a BBB, bundle branch block. So when our QRS is wider than normal, now remember a normal QRS size is 0.06 to 0.11. When the QRS is wider than that, so it's 0.12 or greater, it can be caused by a conduction delay down one of the bundle branches. If the pathway of a bundle is blocked, the conduction has to go through cell-to-cell conduction. That's going to take longer, which is going to make it abnormally shaped. Now we're going to learn in a later class that when we get wide funky QRSs, a lot of times we're going to think, okay, we've got a ventricular rhythm, but that's not the case here. This is actually a sinus rhythm with a delayed QRS. And the reason I know it's a sinus rhythm is if I look at this rhythm right here that I have on this strip, again, QRS to QRS to QRS is normal. It's very regularly spaced. My rate is 1, 2, 3, 4, 5, 6, 7, 8, so rate of 80. I have one P wave for each and every QRS, and my P wave looks rounded and symmetrical across my entire strip. That's telling me it's coming from the sinus node. This is not a ventricular rhythm. This is coming from the sinus node. I'm just having a delay going through the bundles. So I start to look at my interval measurements from the beginning of my P wave to the beginning of my QRS. I notice here I have 1, 2, 3, looks like just a hair over 3 boxes. Let me see if I can see it better on this one. 1, 2, 3. So just right around 3 boxes. So that's 0.12. Now my QRS, it's really hard sometimes when you have a bundle branch block to determine where exactly do you measure that QRS. So I don't have a Q wave. It goes up for an R, comes down here, and then instead of the S coming back up, going flat and going into the T wave, my ST segment just scoops down here and it goes into my T wave here. And that's very typical. Usually your ST segment and T wave will flop in the opposite direction. That is part of the bundle branch block. So one thing we have to make the distinction of is this is not a normal size QRS. If this was a normal size QRS, I would say, okay, I also have a QRS and then I have ST segment depression and a T wave inversion, but that's not what I have here. This is part of the bundle branch block. So when my QRS, so from the beginning of this QRS to where I'm looking for where does the ST segment change? Where does it notch or change directions? And you can debate whether it's notching or changing directions here, that J point we talked about, or whether it's notching right here. But either way, I have a wide QRS. I have a QRS here that has 1, 2, so it looks like I have 1, 2, 3, a little over 3 boxes. So I'm about 0.14 for a QRS. So we need to make sure we're understanding that this would be a sinus rhythm with a bundle branch block. That ST segment and T wave change is part of the bundle branch block. I would not look at this strip and say I have a sinus rhythm with ST segment depression and T wave inversion, because that's not what I have. I have a bundle branch block. So this one right here, I have a regular rhythm, QRS to QRS to QRS to QRS is regular. My rate, now this is only marked for 3 seconds up here, so I have 1, 2, 3, 4, so I would have a rate of 80. I have a P wave for each and every QRS, Because remember, if I'm only counting between 3 seconds, I would have to multiply by 20. Now this P wave is flatter, but it's still rounded, it's still symmetrical, it still looks the same across my strip. So my PR interval measurement looks like it is 1, 2, 3, 4 boxes, so it's 0.16, so that's okay. But look at my QRS here. It comes up, it comes down, it notches or changes directions right there. And it looks like here I have 1, 2, it looks like right at 3 boxes. So it would be sinus rhythm with a BBB, sinus rhythm with a bundle branch block. This example here, well, that actually looks like my other strip. 1, 2, 3, 4, 5, 6, 7, 8, right at 80. Looks regular. Has a nice normal rounded P wave. PR interval looks like it is 1, 2, 3, almost 4, so that's okay. QRS looks wide. It looks like I'm at least 3 squares because I'm looking at where does it change. Now I remember when I first started teaching this class, I remember going and seeing the cardiologist and said, where's my J point here? Is this right here where it notches and changes directions, or is this where it notches and changes directions? And, you know, it was funny because one of the cardiologists told me here, one of the cardiologists told me here, and one of the cardiologists said, you know, Kelly, why get all upset about this? It's wide. Regardless of whether you're looking at it from here or you're looking at it from here, you have a wide and bizarre looking QRS. You have a bundle branch block. I wouldn't lose sleep over it. And I think that's good advice. So let's look at this one. It's kind of hard to see the boxes here. So let's look at this one. It's regular. This bottom strip here, QRS to QRS, is regular. Looks like I have 6-second strip markings. Now this QRS doesn't land completely in it, so I'm not going to count that one. I would have 1, 2, 3, 4, 5, 6. So right is 60. Have a P wave for each and every QRS. PR interval looks like it's 1, 2, 3, 4 boxes. That's okay. Now QRS, it goes up, it comes down, and then it looks like it notches over here. So I would measure that, and it looks like here I have 1, 2, 3, about 3.5 almost. So it would be about 0.14. So it would be a sinus rhythm at 60 with a BBB. Now, to determine if it's a bundle branch block or a ventricular complex, you have to know where it's originating from. So again, does it have a P wave in front of it? Is it a nice normal rounded sinus P wave? To determine if it's a right or a left bundle branch block, you have to put your patient in an MCL. You cannot determine it from just a regular lead 2. So normal conduction of your ventricles, it starts in the SA node, travels through the atrial pathways, comes to the AV node. AV node holds it for about 0.08 seconds, comes down my bundle of His, and then it comes down my right and left bundle branches. So normally your left side has 2 fascicles to it. Depolarization is faster on the left side than it is the right side, so it'll come down this left side a little quicker. Now, your positive electrode, remember in MCL1, your positive electrode is on the 4th intercostal space to the right of the sternal border. So your positive electrode's over here. So depolarization is going to start in the septum, and it's going to go from left to right. So it's coming towards that positive electrode. So you're going to get a small little baby R, okay? Because it's depolarizing from left to right, and it's just the septum at this point. Then it's going to finish coming down this right ventricle and coming down the left ventricle at the same time. So now it's depolarizing both right and left sides at the same time. Well, the thing you have to remember is, again, left side of the heart, larger muscle mass. It is 3 times thicker than the right side. So it's going to pick up the left side more than it is the right side. And the left side is coming away from this positive electrode. The conduction is coming down this way through the left side, away from this positive electrode. So that is going to give you your nice deep S wave. So you get a little baby R and a nice deep S wave, and that's normal of what you would see with normal conduction in an MCL1. Well, to tell if it's a right or a left bundle, right bundle branch block, you are going to have what we call an RSR prime. You're going to have it's going to go up when that septum depolarizes. It's going to come down when the left ventricle depolarizes, and then when the right ventricle has to repolarize through cell-to-cell conduction, it's going to go up again. So it's an RSR prime. So right bundle branch, RSR prime. Left bundle branch block, it's going to go depolarize through the septum, and then it's going to primarily be seen, it's going to have to come down the left side through cell-to-cell conduction, so it's going to give you a deep waveform. So it almost just looks like a QS waveform. That's our left bundle branch block. So I always remembered it, right is rabbit ears, left is a carrot left in the ground. So if we're looking at a right bundle branch block, so normally we said impulse travels through the septum, comes from left to right, and then it comes through the right bundle and the left bundle at the same time, but because this is the larger muscle mass, this is what's being picked up. But if I have a block right here on the right bundle, it's coming down the septum, it's going to depolarize the septum from left to right, it's going to come down this left ventricle quickly. But now, how's it going to get to this right side? If the block is up here and this bundle is being completely blocked, the only way the right side of the heart is going to get the message is through cell-to-cell conduction. And that's going to take time. Because remember, we talked about our heart having automaticity, it has excitability, it has conductivity. So if this impulse is blocked, the impulse is going to come from here and go through cell-to-cell conduction, which is going to take longer. So septum depolarizes left to right, giving us a small R wave. Impulse continues down the left side of the heart, giving us an S wave, and then it has to travel back through cell-to-cell conduction. And when it does that, I mean, if we think about it here, our positive electrode is over here, so as it's coming up the right side, it's being seen as coming back towards the positive electrode, which gives us our RSR prime. Now again, when the heart repolarizes, it does that through cell-to-cell conduction as well, so you get ST and T wave changes going in the opposite direction. So here it shows you R comes down for an S, goes R to big R prime, and then we have ST and T wave changes just because of the bundle branch block. If something depolarizes abnormally, it tends to repolarize abnormally. So we have to be in V1. If we're in a lead 2, all you can tell me is you have a bundle branch block. If you want to tell me whether it's a right or a left bundle, we have to know that we're in a V1 or MCL1 lead. So here, P wave, I come up for my R, come down for my S, come back up for the R prime, have secondary ST changes, so that would be a right bundle branch block. Here's another example. So I've got a regular rhythm. This doesn't look like a full 6-second strip. It looks a little slow, but it's not a full 6-second strip. I have a P wave that goes part up, part down, and that's normal, we said in MCL. My PR interval, it looks like my PR interval, looks like I'm 1, 2, so from here I'm 1, 2, about 3 boxes, so that's okay. And then my QRS, this is when the septum depolarizes, the left ventricle depolarizes, and then the right depolarizes through cell-to-cell conduction, and then it repolarizes through cell-to-cell conduction. So this would be a sinus rhythm at whatever the rate is with a right bundle branch block. Now left bundle branch blocks, remember we said normally the septum depolarizes from left to right. So here the septum is going to depolarize from right to left because it's blocked here. So it's going to depolarize from right to left. And then as it's depolarizing in this direction, so our positive electrode's over here, so it's going to be seen as going away from the positive electrode. The impulse is going to keep traveling down through that left ventricle. It's going to come quickly. So as it's depolarizing from right to left, it's going through cell-to-cell conduction, which takes longer. That impulse is still traveling up here. And then as it's coming through here, it's all through cell-to-cell conduction, which is going away from my positive electrode, which is going to give me a nice deep QS waveform. So septal depolarization is abnormal. Impulse travels down the right bundle quickly, then continues through the left, giving us our wide QRS. Since the left ventricle is the largest muscle mass, the ECG is going to show you a QS waveform, and it's going to just look like a deep QS, and you're still going to get secondary ST and T wave changes. So it will look something like this. I'll still have my P wave, and then I'll have a deep QS, like a carrot left in the ground. So again, I have to be in MCL. Right bundle branch is an RSR prime, left bundle branch block is a deep QS wave or a carrot left in the ground. Here's one more example of it. I can see my P wave. I've got this nice big wide QRS. But the hallmark of this is I still have that sinus P wave.